And good evening. That's right, I'm back. And welcome to Bite-Sized Learning from the Ohio Academy of Family Physicians. I am your host and president of the Ohio Academy of Family Physicians, Dr. Mike Sevilla. And we have a great program coming up for you here this evening. But before that, I do just want to mention just a couple of things on behalf of the Ohio Academy of Family Physicians. First, I just want to mention our webinar that we have coming up on April 22nd from 7 to 8:30 p.m. It's called Challenging Race-Based Medicine in Practice. This is something that is very popular, and it's a popular topic, and it is a needed topic. So you can get more information about that important webinar at ohioafp.org. And then also want to mention our book club that's been very popular this year, our Health Equity and Social Justice discussion book club. And let's see, so May is the book My Grandmother's Hands, and our moderator will be Dr. Kathleen Meehan Dela Cruz, and that will be on Thursday, May 13th at 7:30 p.m. I don't want to get into too much detail about it. You get more information at ohioafp.org. And finally, yes, I will mention the merch. Our foundation, the Ohio AFP Foundation, has great merchandise. You can get your T-shirts that say, "Proud to be a vaccinated OAFP family physician." And those proceeds go to our medical student programs, particularly the summer preceptorship program, which I am an alum of, and also teach medical students through that too. So very exciting stuff going on here at the Ohio Academy of Family Physicians. You can always get more information at ohioafp.org. So we have a great program tonight. Topic is orthopedic surgeon hip and knee reconstruction, sponsored by Orthopedic ONE, and we'll bring in our panelists here. We have Dr. Graham Pallante and Philip Schultz from Orthopedic ONE. Welcome, gentlemen.
Thank you.
Yeah, thanks for having me.
So before we get to our topic, Philip, why don't you tell us a little bit about Orthopedic ONE? And again, thank you to Orthopedic ONE for your continued support and sponsorship of OAFP events and programming. Tell us a little bit about the organization and what you guys do.
Well, thank you, Dr. Sevilla. I would just like to say first, we are honored to continue to partner with the OAFP. We are going on our 6th year of sponsoring and being a part of different events that the OAFP puts on every year. And we just think it's an awesome thing. So we're happy to be here, happy to continue to sponsor, and happy to continue to provide education in the musculoskeletal area for physicians. A little bit about Orthopedic ONE. I know we have an audience that kind of goes all around Ohio. So we are located in central Ohio. But we are the biggest orthopedic practice in the state. We are a privately owned group of physicians. We practice out of both Ohio Health and Mount Carmel hospitals in central Ohio. We have 60 physicians in 9 locations, and we cover every subspecialty you can imagine. And we're just happy to be here, happy to have Dr. Pallante speak to you this evening. And please feel free to reach out to myself if you ever have any questions, you'd like to connect with one of our physicians, or learn more about Orthopedic ONE, please feel free to reach out to Caitlin McGuffey to get more information on that. So thank you, and we're happy to be here.
Cool. Well, thank you so much. So as we get Dr. Pallante's slides up here, Philip, how can people reach out to you? I think I did see a website and other ways people can get more information about you as we get his slides up.
Yes, that's right. The easiest way to learn more information is to go to our website, which is www.orthopedicone.com. We have information about our physicians. We have a referring provider tab, so you're able to click and download a resource guide that has a number of different bits of information in there, and so you can do that. If you'd like to reach out to me personally, My email address is pschultz, PSCHULTZ at orthopedicone.com. Caitlin can get you that information. And if you have any questions further than that, feel free to give me a call or a text 740-504-0554. And again, Caitlin can help you with any of that as well.
Great. Thank you so much. All right. So welcome, Dr. Pallante, Graham. Thanks for the time tonight. So just to let the audience know, he has some slides here that he's going to present, and then I'm going to interrupt him with questions because that'll be a lot more entertaining than him reading slides to us. So Dr. Graham, go ahead and start your remarks there, and then we can have a conversation about this. So thank you for being here tonight.
Yeah, absolutely. Thanks for having me. My name's Graham Pallante. My specialty is hip and knee replacement. And so that's kind of the focus of what I was going to talk about tonight. I basically was going to update you guys on kind of what kind of the new conversations are, at least around the hip and knee replacement world. And hopefully some of that's relevant because maybe some patients are coming into the office asking some of these questions. And I can kind of hopefully provide some updated information that if these questions come across your desk, then maybe be able to answer a little easier. About me, I guess. So I am originally from Granville. I married a hospitalist. Her name's Angeline. She's in that picture there. And then I have a 2-year-old son and my 2-week-old daughter. I cropped into that slide.
Wow.
So she's fresh. She has her little Easter outfit on there. But so things are a little crazy around the house right now. I basically from Central Ohio. I did my undergrad and med school in the area, and then I did residency in Minnesota at Mayo Clinic, and I did my fellowship in Cleveland and came back here to Orthopedic ONE, and I work basically in various satellites around the city. Right now, Grove City, Westerville, and Taylor Station are where I see patients, and I operate mostly at the Mount Carmel facilities in Columbus. So these are the three main things I was going to kind of update on. It seems like everyone is talking about anterior approach hips, and that's been going on for about the past 10 years or so. And some of the questions that come up are, am I going to recover faster? Do I have fewer complications? Is it better? And where can I go to have it done that way? And then one of the hotter topics in hip and knee replacement right now is as we move towards doing this as an outpatient, is that safe, and who can we do that with? And then thirdly, robotics. That's kind of the newer of all these three topics, and the big question there is it really better? So I was just going to give a little background on what the different approaches are for hip replacement, just to demystify that a little bit. Really, all of them are in relationship to the abductor muscle, the gluteus medius, which is kind of right there in the center of the picture there. And then you can see the dotted lines are basically the three main approaches that are done. And the anterior is the one that goes in front of the abductors, posterior goes behind, and lateral kind of goes through the abductors. So anterior and posterior for first-time hip and knee replacement, those are kind of the workhorse approaches. And the posterior is the one that has been more historically done and is still more common across the US. And then this is just a little bit of a more detailed illustration kind of showing you the comparison of the two. And again, it's a little hard to tell because the pictures are from different books, but basically that middle one in the lateral approach is going through the abductors and then flanking on either side, the posterior and anterior going in front and behind. And that top row is kind of where the incisions are. Those are admittedly a little bit bigger than you'll actually see in a patient.
Now, if I could jump in there. So I guess historically, in the past, it has been the posterior approach, and there's just this newer technology and developmentally, as far as from an orthopedic standpoint, the anterior approach has been more looked at and has been more used now, and it's even even more widely used now. Would that be fair to say?
Yeah, it's definitely become more popular. It's gaining popularity, I think, especially as residents and fellows train more and more in it. There's obviously a lag time there where first we had to prove that it was at least as good as the posterior approach, and then people started to think, well, maybe it's even a little bit better. And then those people had to start training people, and so in order for that paradigm shift to happen, it takes many, many years, and I think we're kind of in the middle of that right now.
Okay. Yeah, I know you're going to talk about advantages in your next slide there, so we can jump into that.
Yeah. So not all these are data-based advantages, but some are. But in general, the thought behind doing the anterior approach is it's muscle sparing. You don't actually cut any muscle in general when you're going through the front, where you do from the lateral and posterior approach. That we think maybe allows for less immediate post-operative pain. The other big possible advantage is, depending on the surgeon, a lot of times you won't have any restrictions after surgery. So from a posterior approach particularly, there are certain movements that physical therapists will train patients not to do, like bending their hip past 90 degrees, trying to pick things up off the ground. And so they'll have those restrictions for 3 months and sometimes more. So doing the anterior approach, you can basically tell patients post-operatively, don't worry about it, just do what doesn't hurt. As far as the dislocation rate, it's definitely lower, and that is data-based from the front. Dislocation from the back is a little bit more common. Another benefit is doing the anterior approach. The patient is laying on their back on the operating table as opposed to their side, so you can much more easily use intraoperative x-ray, and you can put the implants more where you want them, and you can also really dial in leg lengths, which if someone is lengthened by a significant amount, they'll notice, and sometimes they'll be unhappy about that. So that's one thing that's pretty avoidable, doing the hip from the front. And then the only real good randomized trial comparing the two showed a benefit of getting off of a walker or cane a little bit sooner from the anterior approach as compared to the posterior.
So in the posterior, one of the things that were happening was that people were having different leg lengths, and sometimes you would not know that until following the surgery or during your therapy. If a patient did have a posterior approach, and I guess what I'm hearing you saying is, when they do this different procedure approach through the anterior, you would know that right away. You'd be able to correct that, like in the operating room. Is that right?
Yeah, that's exactly right. The benefits are kind of the dislocation rate and the leg length rate kind of go hand in hand. You're less worried about dislocation, so you're less worried about adding length, for which subsequently adds stability. So there's that, and you have the x-ray. You can use anatomic landmarks in surgery with your x-ray to make sure you're not over lengthening the limb. Whereas when you're doing the posterior approach, you can't really reliably use an x-ray in surgery. And so you're relying just on feeling the legs on the operating room table, which is a pretty unreliable check. And it's hard to really get things dialed in within millimeters like you can from the front. So every once in a while, someone will notice, oh, my leg feels a little bit longer, the side that you operated on. And most of the time that kind of doesn't persist. But every once in a while, if someone gets lengthened a lot, they'll notice it and be unhappy and end up wearing a shoe lift on the other side. And that's the patient that you can potentially avoid going through the front.
Now, a question I get, and probably you get as well, especially from patients, is like, the amount of time under anesthesia, the type of anesthesia. Is there any difference between the anterior and posterior? Can you address those questions?
Yeah, absolutely. In general, anterior approach takes a little bit longer. It's just a little bit more technically demanding. And so there are a few more steps you have to do, especially if you're using x-ray too. It takes a little bit longer. I would say on average, you're talking about 30 to 45 minute difference under anesthesia. whether that truly clinically is relevant is probably up for debate. Most people are not using any different anesthetics. They're still open to the full range of anesthetics at the time of surgery, and they're not using catheters, which would be placing patients at higher risk for infection or urinary retention post-op. So I don't think that the difference in anesthetic time is in general probably clinically relevant, but it does take longer.
Okay. I know we've talked about advantages. I know we'll be talking about disadvantages to this technique.
Yes. Yeah. So one of the things that's talked about a lot is there's a learning curve for sure doing anterior approach hips. Even if you train doing it, most people say it's a 1 to 200 case learning curve where your complications are generally higher. Again, just because it's a little more technically demanding, there's a little less visualization during the surgery, and so you can run into more problems than you do necessarily from other approaches. It's also difficult in patients with high BMIs, particularly once you get above the 40 range. And at that point, you kind of should question whether or not they're a good candidate for having hip replacement in general. But muscular men who have high BMIs are probably the hardest patients to do it. And so for me, I sometimes am selective about who I offer it to. It is poorly extensile, so if you run into a major complication or if it's like an intraoperative fracture or something like that, it is hard to change gears and extend your incision and change the surgery. So you can do the total hip through the incision, but then to do additional work, sometimes it's very difficult. And there have been situations where you've had to take the patient off the table and switch operating room tables while they're asleep to deal with the complication. You need special equipment to do it, so the hospital has to buy a special table called the HANA table. There are other brands, but generally those are a couple $100,000 expense at least. We talked about the increased surgical time. There's an increased risk of intraoperative fracture, and because of where the wound is very close to the groin crease, there's a little bit higher rate of wound complications and thigh numbness because you run into that cutaneous nerve that you hear about in truckers who wear their belt too tight. And people get that lateral femoral cutaneous nerve palsy sometimes is permanent. But most people don't really notice that long term.
Yeah, I'm on. I used to be on our hospital board for our community hospital here, and when our surgeon came in doing this anterior approach, I know how much that table costs. So it is a big price tag for any hospital, but especially for a small community hospital. But you know, it's been widely accepted, and you know, a lot of people come from out of the county and to come to see this surgeon because you know, we're seeing the benefits from that as well. Now, you did mention a little bit about BMI. Are there other kind of factors which would make you know, a poor patient choice for an anterior approach procedure?
Yeah, I mean, besides just BMI, there are some people, and I'll still try it on them just with a little bit different post-operative plan, but some people who've had, for example, bariatric surgery, and they'll have a large pannus or something where they have skin hanging over the front of their thighs. That makes you worried about the wound. There are also some anatomic factors. People with a really wide pelvis and simultaneously short femoral neck make the exposure very difficult, or certain basically arthritic conditions that are different than standard osteoarthritis, where you have like a rheumatoid arthritis patient and the femoral head is eroded into the pelvis way medially. It can be very difficult to get exposure, but those are more technical aspects of it that I think surgeons differ on what they'll tolerate and what they'll try from the front.
Yeah, yeah. Are there sometimes patients where you say, hey, you know, just with your medical history and your medical problems, you know, I mean, this would not probably be a best type of option for you? I presume you have patients who approach you and you have to kind of break the bad news to them that this is probably not going to work for you, or you're at high risk for complications and that type of thing.
Definitely. Yeah. I've had fewer patients asking specifically to get the anterior approach than I expected to in practice. But even that being said, not everybody's a candidate, and so I selectively do it for the people that I think will do well with it. But if I do not think that it makes sense, I'll tell them, hey, we need to go from the posterior approach. And the reality is, it's such the differences between the approaches are so subtle that I don't expect them to have any worse of an outcome. And most of the time, those people are pretty understanding. As long as you tell them, your anatomy just it dictates that we do it a little bit differently. And people understand that and often appreciate that that they're being considered and the surgery is being planned specifically for them.
Yeah, I kind of cheated into your next slide. So, how do you decide, and how do you talk with a patient which is the best approach for them?
Yeah, I think everybody's going to give you a little bit of a different take on this because it's so close in outcome to the posterior approach. I think some people feel strongly one way or the other. I think for me, the lower dislocation rate, the post-operative restrictions being freed up, having X-ray to make sure that I'm putting everything exactly where I want it, and the possibility of having a faster recovery. And anecdotally, I see that in the hospital. I do it. If someone's a candidate, I do it for those reasons. But again, long-term, especially at a year, there's really no difference as far as pain relief, mobility, function, all that stuff is the same. So I think what's most important, and what I would tell patients who are questioning it, is really you want to choose a surgeon that you're comfortable with rather than choose your doctor based on what approach they do. Because no matter what, if they have bad hip arthritis and they get through the surgery without a complication, they're gonna do great. Hip replacement is just one of the most successful surgeries in medicine. And much better than knee replacement. People are very happy who get through it without a complication.
Now, I have patients all the time. Obviously, I advise them too. Maybe get a first opinion, second opinion, just to kind of see what will be best for them. I have people going from Cleveland to Akron to Youngstown, and so how would you advise patients on how much experience their surgeon has had with anterior approach or basically any kind of orthopedic procedure? Is that something that you put out, or you talk with patients about, or is that something that is put out on a website somewhere? Or how would you advise patients just to try to see how much experience their surgeon has had before they would kind of dive into any kind of orthopedic procedure?
Yeah, that's a great question. I don't know how, as a patient, you would actually find, what are the case numbers for this surgeon? How many of these have you done? Have you done the 200 anterior approaches that are required for you to eclipse that learning curve or whatever that we talked about? I don't know that there are any good ways to find that out without directly asking the surgeon yourself. To be honest, patients find things out through social media or other channels, and I find myself continuously surprised by some of the statistics that I hear from patients, like, oh, you're ranked such and such, and I don't even know about ranking systems at all in orthopedic surgery. So there's a lot of information out there, some of it good, some of it not so good, that patients find out, I think. But you can't really find those numbers on a website or even by calling. I think you'd have to talk to the surgeon specifically to know exactly what their experience is.
Yeah, I mean, I would guess probably just from their training pedigree as well,
Right.
as far as where they trained at. So the surgeon that is here trained out in Southern California somewhere, some kind of orthopedic institute there. So I guess like a lot of things in medicine. I mean, there's reputable training programs which patients can easily look for and see. So I mean, just with your credentials, as we began this talk, I mean, people can know that you're credentialed and know that you're experienced. So I'm just kind of curious if you knew any kind of inside information that could help out patients when it comes to something like this. But obviously, any kind of operative procedure can be a big deal to them.
Absolutely, yeah, and I think that's an important thing. People specifically when we have hip and knee replacement, they do a lot of research. They do look at those things. They look at where you trained, what practice you're in, what hospital you operate at. And I think there's a lot of word of mouth involved within those patient circles. So they tend to already know by the time they get to the office a lot about me. And I think that's a good thing. But I think that's where I would direct them. Go to the website, look at bios, look at training, look at reviews online, and that's what they do generally.
Yeah, and one of the things with anterior approach is that but people are in the hospital a lot less days, and I know that's your next topic. It's just really interesting how orthopedics and a lot of outpatient surgeries are progressing as far as having less time in the hospital, and I know that's your next slide there.
Yeah, I do think anterior approach facilitates a little bit more efficiency as far as hospital stay goes. That's not a data-driven opinion, but anecdotally, they feel better quicker, and it's easier for them to get up and move, which then facilitates them going home. And we've come a long way in the past 10 or 20 years in every kind of step of the way as far as a total joint, from the pre-op discussion, the education side of things, through the anesthetic and early post-op management. And so now it is, I think, pretty safe for people to have a hip or knee replacement done as an outpatient if it's the right person. And with, efficiency and cost containment being such a priority, especially recently, we have to continue to move towards that. And we've been pushed a little bit by that. And now hip and knee replacement are off of the inpatient only list. And so they can be done in an outpatient setting or an outpatient overnight setting, like a 23-hour observation setting.
Yeah, it's amazing. I've been taking care of patients in the hospital here, 20 years or so. And I remember when I started, when people had their hip with their posterior approach, you would, allot certain days inpatient, and then allot certain days in the rehab unit in our hospital here, and then you go, outpatient and home. And now that all that time is now all shortened, which is great for patients, now that you have the great results. But you're right. I mean, it's been such a huge change in just a short period of time, in a decade or so.
Right. And I think,
go ahead.
Yeah. So I think as far as making it work, it's mostly about expectations and patient selection. Those are probably the two most important things. And I think if patients are expecting to have an outpatient or a one-night stay in the hospital, then they're much more comfortable with it than if they're expecting to spend 2 or 3 nights in the hospital and you tell them at the last minute or post-operatively, oh, we're going to get you home tomorrow. They are very uncomfortable with that. So starting in the office from the very beginning, telling them what to expect as far as their post-operative course is important. And then selecting patients that you think are going to do well with that, who have a lot of support, who are healthy, don't have significant medical problems, or don't have something that you're going to want to monitor in the hospital post-operatively. And then those other few points on there, I mean, you have to be doing this with a team that's used to it. You don't want to be doing the first ever hip or knee replacement as an outpatient with no one who knows how to do any of that stuff and is not trained in it. So you want to have kind of a process already. And that kind of feathers into the next point, which is having multimodal pain management that doesn't just rely on opioids, very strategic anesthesia, blood conservation strategies in surgery so they don't lose a bunch of blood or lightheaded when they get up, and making sure you have physical therapists on site to get them up safely and start mobilizing them within a few hours after surgery. And then really have to plan for the common complications and do things perioperatively to try to avoid them.
Yeah, just so much of a change, and I get a lot of questions for patients about opioids, and I know you probably do too. And I remember when patients expected to receive a blood transfusion, their own blood transfusion during some of these procedures.
Right.
and that's hardly even talked about anymore. I think that's part of the process of change and advancements in not only hips but a lot of orthopedic procedures.
Right. And this is a slide where these are like the kind of patient, what they'll bring up as worries. I'm worried that my pain's not going to be controlled. I'm worried that I'm not going to have enough support at home. My loved ones aren't going to be able to help take care of me. I'm very worried about falling, and those are definitely real concerns. And then if you ask patients, what are the benefits of maybe doing this as an outpatient, they'll say, well, at least I could sleep in my own bed. I don't have to be in the hospital where people are coming and waking me up every 2 hours. I'm not around a bunch of infection in the hospital, and maybe my recovery would be faster. But on the next slide, I go a little bit more in detail about how we select patients. These are kind of the specific things I use. It's going to be different a little bit for everybody, but really elderly people I try to keep them in the hospital. And then, medical comorbidities are best dealt with in the hospital for sure. I think one of the ones that you really have to key into and be careful about is the patient that's healthy but is really deconditioned. They come into the office in a wheelchair. They're really unstable. Those people, you probably need them in the hospital to give them a little bit more time with physical therapy and make sure that they're not going to fall when they leave. And then again, social support, home environment needs to be safe. If they live on the 3rd floor apartment and they have 3 flights of stairs to go up, you don't want to probably send them home on the same day. In the end, you want to avoid any kind of really complicated surgery where there's deformity or weird anatomy or revision surgery. That takes longer. You can run into problems, and you don't want to be doing that at a surgery center. And then, most people expect to stay in the hospital 1 or 2 days. So again, if you talk to them ahead of time and you say, well, we might be able to get you home on the same day, that works much better if everybody's on the same page. You've got the education, you've got the total joint class. I have them see physical therapy ahead of time because at that appointment they can say, okay, this is how we set up your home so that it's safe when you get there. We can get you your walker, your crutches. We can show you how to use those. And then communication after they have the surgery is also super important. So I try to call them either the same day or the next day after their surgery and check in. And then we always have their PT, their follow-up, all that stuff is already set up so they don't worry about having to deal with that after they get home.
Yeah, I only have anecdotal evidence of this. I don't know if there's any scientific evidence of this, but I've had some patients who are so motivated that they start some of their home therapy even before surgery. Is that more helpful, or is that not really helpful, or what's your experience been with that?
I do have some patients that want to know, should I do that? I think as long as it doesn't make them have more pain, I think it's fine to do. I don't think it makes any sense really to go home and really suffer and try to do all this walking or exercising if it's just going to spiral their pain out of control. So I tell them, let pain be your guide. And if it's really difficult for you, I don't think it matters that much. But if it's something that you can do with minimal or tolerable pain, then it probably does help you a little bit.
Okay, makes sense.
But I think the data on it shows that doing true focused physical therapy ahead of a hip and knee replacement hasn't really been shown to improve outcomes post-operatively. So I'm not very regimented about it. I do think the education side of the physical therapy makes a difference though. And this slide is really, I just wanted to kind of talk through how it would go if you were to have an outpatient hip or knee replacement. Basically the patient shows up early in the morning, they need anesthesia, and then we do this kind of multimodal cocktail ahead of time. We give them dexamethasone, we give them Celebrex, we give them a motor sparing nerve block for total knees. We don't really give nerve blocks for total hips. Some people give a short acting spinal anesthetic. I like a general anesthetic. I've just anecdotally had less urinary issues after a general anesthetic. and most people are giving some kind of local anesthetic intraoperatively too. The procedure hopefully isn't taking more than 2 hours. If it is, then you're starting to wonder about having issues at waking up, having sort of a prolonged kind of recovery course in the PACU. Most people, that takes about 1 or 2 hours before they're ready to get up. And then we have their family or their support person come in, and they're there for the physical therapy so they can see how it's done and what it's going to look like once they get home. And then they leave. And we have, I make sure everybody has a multimodal pain regimen, which can be a little overwhelming for patients, admittedly. I send them home with a whole stack of prescriptions, but as long as we educate them ahead of time, I think it makes a big difference. They're taking way less narcotic, and I'm having to fill way fewer opioid refills with that. And I think it helps to have the steroids, even though they're a slight infection risk early on. They help a lot with the nausea. They help a lot with the pain. And doing a short course, it has been shown that it doesn't actually increase infection. So that's what I do. I do like 5 days of steroids, and then I add these other medicines along with it. And the common complications that we're trying to avoid, we do various things intraoperatively and postoperatively to mitigate those risks. So urinary retention, long-acting spinals are bad for that. We avoid using catheters. For the hypotension, we make sure that we're managing fluids. Tranexamic acid has been kind of a huge advancement in orthopedic surgery. We're seeing way less issues with blood loss, way less transfusion. Transfusion's like extremely rare after a primary hip and knee at this point. Hematomas are not a big problem, and it's all really related to this widespread use of tranexamic acid, which is relatively safe and can be given to almost anybody. And then nausea and vomiting, we were using, a lot of this is being treated with the IV steroids that we give ahead of time and the post-op steroids, and Zofran.
And what do you share with patients about potential of infection, especially those patients with diabetes who may have some struggles with wound healing and things?
Absolutely. I tell everybody that there's probably, it depends on every hospital and surgeon's different. For me, I quote them about a 1% risk with all risk factors eliminated. If they have those risk factors, if they're a smoker, if they're overweight, if they're diabetic, if they have multiple of those, it's going to be higher for them. And I usually tell them, what that involves. And most people are receptive to that. Infection after hip and knee is such a life-changing problem that people are very receptive to me telling them, hey, this is really risky, and they will help. I'll help them modify those risk factors that are modifiable, particularly smoking and their weight, because a two-stage exchange is a huge deal where you're taking out a hip, you're giving them an antibiotic spacer, maybe clearing the infection, then going back in and doing another surgery to replace their hip or knee. It's at least a 6-month process, usually more. So I do give them the scare speech a little bit on that. And sometimes, you can't avoid it. You do everything right, it still happens. And I say that's about a 1% risk.
Yeah, and your slide here says anticipate complications. I presume that means anticipate potentially rare complications that may happen.
Right.
Are these are all these on the screen? Are these potentially like 1% or a little bit higher than that? Or
yeah, these are a little bit higher. These are probably I would call these common complications. These are things that we run into. I don't have a great number. I would say 10 or 20% of the time for most of these. Nausea, vomiting, probably higher. And these are the things that are going to potentially delay discharge or make you stay overnight.
Okay, gotcha.
So these complications, I guess, are specific to trying to get this done as an outpatient. And so, somebody who can't pee, or they're too dizzy to get up a physical therapy, or they're so nauseous they can't keep food down, those people aren't going to be sent home. And so if you can mitigate those risks and kind of get out in front of them, you can kind of have a higher success rate of getting people out of the hospital and avoiding kind of unexpected overnight stays or prolonged hospital stays.
Gotcha.
Then yeah, is it better? I think it in general, anecdotally, people are happy who do this. That the true outpatient hip, which is different than an outpatient overnight hip or knee, which is what I would say most of my patients are. I think most people could fall under the category of 23-hour overnight. But true outpatient surgery center hips and knees, that's a lot more rare for me. The ones that qualify for it and go through the process are happy though. They like it. They like sleeping at home. They feel like the way that the pathway works, that they feel comfortable. So in general, I think it's a good thing for the right patient as long as you educate them. And potentially there's a good cost savings that can be realized if you can go through that process and select the right patients. It's hard. Cost is always really complicated though. So I don't know, admittedly, what that long-term will shake out as, but in general, I think most of the studies will show there's some amount of savings doing it at a surgery center versus the hospital.
And before we go on to your last topic of robotics, I mean, I have a lot of my patients, and probably for you too, the question comes up, should I have my joint replacement, during this COVID-19 pandemic, and how do you manage those expectations and fears and concerns?
I got most of your question. I think it was just about how do you manage expectations in the COVID-19 pandemic with hip replacement. And admittedly, last year it was a little tougher. It was a little more touch and go because it was like, well, I don't know if we get shut down again. I don't know if we're going to have to delay your surgery. That was part of the conversation. Fortunately, now I think that's not really a major factor. As far as scheduling goes, as far as risk of infection, risk of getting COVID-19 in the hospital, it definitely makes, patients want this outpatient process a little bit more. I don't know really whether it's actually any safer than doing it in the hospital because you're still interacting with roughly the similar number of people. I guess you're not going into the facility, but in general, everyone who goes through a hip or knee has to have a negative COVID test within 72 hours of their surgery. And theoretically, they're quarantining between the time of that test and the time of their surgery. So from a patient perspective, it's pretty unlikely that we're operating on people with COVID. Really, I think where the unexpected COVID-19 infections are coming in are, employees who are passing their screening, but are asymptomatic and interacting with patients. And that fortunately has not been a common thing. I've seen maybe one or two over the last year, unexpected COVID infections that I know about that almost definitely happened during the post-operative course in the hospital or in the surgery center after a hip or knee replacement.
So I'm very excited about your thoughts on robotics and the latest on robotics. What do you have to say about that? Yeah.
The picture on this slide, these are like the three main robot platforms. And the left one is Zimmer, the middle one is Stryker, the one on the right is DePuy. And those are probably the biggest implant manufacturers in hip and knee replacement. And so they all have their own robot, and they're coming out with technology constantly updating these platforms because it's definitely the new craze. Whether it's truly better or not, I think is up for debate. I have most experience with the one in the middle, the Stryker, that's called the Mako robot. And that is one that you have to have a certification to do hips, knees, and partial knees. The other two, I don't know if you actually need certification to do them, but they all work kind of similarly. And I think in the coming slides, I kind of show you how they work a little bit, just so you have this is a patient video that I just spliced the relevant part. It's like a minute long, I think. know if it's going to play for us or not. But basically, what you have to do with the Mako robot, you get a CT of whatever joint, and that is basically programmed into the software. And then in surgery, you take a probe and you basically do what's called register the knee or the hip, and you have to register all these points anatomically during surgery. And once you complete that process, you use that robotic arm with the saw blade attached to it to make the bony cuts in the knee or the hip. And basically, there's haptic feedback, so you cut within a millimeter every time, exactly the way that you planned it, which you do preoperatively. You can adjust that plan intraoperatively as needed as well. And then the rest of the surgery is basically exactly the same as a knee replacement. So really what it's used for is making the bone cuts and then positioning the implants. And it does a very good job of that. I mean, it's extremely accurate. Whether we know where the right place to put the implants are, the right place to put the bone cuts is, that's really the debate.
Wow. Cool.
So yeah, this is like the nitty gritty of it a little bit, but most of the advantages are really, you can put the implants exactly where you want. What the right position is, we don't know. It does have a potential benefit in complex problems with deformity and where you're having trouble seeing. You can use the CT scan to guide you. And there's a possible increase in early motion after knee replacement because you're doing a little bit less soft tissue work to do the bone cuts. But disadvantages are like you might expect. There's a learning curve. It takes longer because you got to do all that registering intraoperatively. You may need a CT scan. You may need additional X-rays, which cost money and are not easy for the patient. There's extra radiation. Garbage in, garbage out. Basically, I just mean if you tell the robot, I want to make my bone cut here. If that's the wrong place to make your bone cut, the robot's not helping you. It's not going to tell you that's the wrong thing to do. And then they're very costly. It's not just the price of the robot; it's everything that goes with it. They have employees that are constantly there servicing the robot and working with the surgeon in the operating room. There are all additional drapes and other disposable materials that they need. And then there's a separate area where the images are analyzed and the implants are positioned in 3 dimensions on the CT scan. So all of that costs money. And so what the big debate is, or what the companies will tell you is, well, you're going to save money in the long term because these patients are going to do better and they're going to be happier. And so there's going to be less reoperations, less hospitalizations, less manipulations under anesthesia. We haven't seen that yet. It's probably too new to really know. But there are some early studies that are company sponsored, as you might imagine, that say that those costs kind of balance out in the long term. I don't know if I believe that, though. So, yeah, I mean, I kind of gave you my opinion about it a little bit. I think it's a hot topic. It's definitely kind of patients hear, a robotic knee, robotic hip. It sounds fancy. I don't think it's really at this point significantly different from an outcome perspective. But we really need more time to know. And that particular technology is really advancing quickly. It's only been around for about 5 years in any kind of mainstream way, and even within that time frame, it's changed quite a bit, and it will continue to do so. And I think it's probably where things are going to go in the next 10 to 20 years. I think it's going to become more and more common, and it already has. I mean, especially with the Mako robot, they're all over the place now. Where if even 5 years ago, I think that technology came out in 2014. So if you looked in 16 or 17, it was exponentially fewer robots around the state, at least.
So you yourself, you use the robot for your joint procedures?
I have in the past. I don't currently, because my hospital doesn't have one. But if I had access to one, I might. I don't know that. Like I said, I don't know if it's significantly different. I don't think patients do any better or worse. I think it's just an extra. It's an extra bit of technology that has good utility in a very select group of like deformity type patients or complex scenarios where you can't use normal instrumentation, and that's what I would use it for.
Now, do other surgeons at Orthopedic ONE use a robot, or? Yeah,
there are robots at Riverside Hospital and some of the other surgery centers that Orthopedic ONE uses.
I mean, I guess where I'm getting at is, would a patient be able to say, "Hey, I want to talk to a surgeon who uses a robot because I have questions"? Would that be available to them or not? Or
absolutely, yeah. There are several surgeons in the practice. I mean, who use it, and if they were seeking that specifically, they would absolutely be able to talk to any surgeon would be able to educate them on it. And if they really wanted to have their knee or hip done robotically, they could be referred within the practice to someone who does that.
Okay, good to know. Good to know. Yeah. So, I know your last slide here, you have some other brief things you just wanted to mention as far as fun things in your world.
Yeah, these are their own kind of talks in themselves, you know. But in case we had extra time, I had these here. We could get into some of it, but really the long and short of it is weight management is something that I'm talking about every office day. And when is it too risky from an infection standpoint to do it is really, I use BMI as 40 as a guide. Some people talk about that as a cutoff. I don't really have a cutoff, but I do talk to people who are in that range and above about the significantly increased risk of hip and knee replacement in that group. And we always try to get them down to that 40 or below level ahead of time before we engage in a hip or knee replacement. And if they can't at least demonstrate some amount of weight loss, I usually say we can't do the joint. But everybody's a little different on that. That is a huge issue in hip and knee replacement. And as you might imagine, the heavier people tend to have more arthritis and be more symptomatic from their arthritis. So we're definitely seeing a disproportionate number of those patients. And so we still need to work hard in that patient population because they also have the most complications. And those complications, when they do happen, are the hardest to fix. The anticoagulation part, I think, without getting in the weeds on that, most people are using aspirin. Most people are actually using that 81 milligram aspirin twice daily because some recent data for DVT prophylaxis wise has shown that that's not significantly different than the 325 milligrams. So that's what I do for uncomplicated primary hips and knees. I use 81 milligram aspirin twice a day. The other ones I don't think are being used routinely as DVT prophylaxis. And then the last thing is that non-operative management. I mean, we could go all night about different things that we can do in that. And when has it truly failed? I think most people would say for knee arthritis, doing at least some form of therapy, whether that's a home exercise program or dedicated physical therapy, doing at least one round of injections just to prove that the pain is coming from the knee, prove that during the anesthetic phase, at least they got some relief, is probably a requirement. And for hip arthritis, it's a little bit looser. It's I think mostly, have you tried NSAIDs and is it horribly impacting your life? I don't think injections are very successful for hip arthritis, so I don't really harp on those nearly as much as I do for knees. And physical therapy, again, for hip arthritis is, if it's bad hip arthritis, it's not usually very beneficial.
Yes. And unfortunately, as you already know, and as I talk with my patients, sometimes there are certain hoops to jump through from our friends at the insurance company to get to you and to get to your operative expertise. But again, that's for another show. And I love this slide here. This is probably taken at the last Ohio State basketball game, which is a whole nother show, which we won't talk about. I think I have peppered my questions probably too much, but before we before I let you go, I mean, I always talk too much. I tell people half an hour, and I always go an hour. You have any closing thoughts for our audience? I mean, I know that this has been a very comprehensive talk in your slides, and this will be available for people to view on demand. But do you have any closing thoughts for our audience is about joint or joint replacement or anything orthopedic in general before we close things up tonight?
Oh, I just think all these things that we talked about tonight, I think they highlight sort of the ever-changing hip and knee replacement kind of landscape. I think we're constantly working to try to make that process easier for patients and better for patients, and I think we've done a good job of that. There's still a lot of room to go, particularly with knee replacement. And so as the field continues to evolve, I think there are going to be more and more advances coming in the next 10, 15 years that are really going to continue to make this a safe and effective process for people. Cool.
Well, Dr. Graham Pallante, thank you so much for the time tonight. Thank you. We should bring you back at some point I can go an hour also on anticoagulation, and that's you on that. But before we close up, again, I want to thank Orthopedic ONE, orthopedic1.com, for sponsoring tonight's program and for continued support of Ohio Academy of Family Physicians. And you can watch this on the replay. You can go to ohioafp.org to watch this program or any of our previous bite-size programs, which are actually not bite-size, but appreciate everybody viewing this. So thanks everybody for the time tonight. Have a great week, and we will talk to you all very soon. So good night, everybody.